Hello and welcome to the EMSNation podcast, which is of course headquartered out of New York State. Today I'm joined by none other than Medical Director Dr. Chris Fullagar. Chris, welcome back to the show.
Thank you very much, Faizan. It is a pleasure to be here.
So you have been instrumental and an incredible part of developing and updating the protocols for New York State. And a couple years back, we had convened to discuss the collaborative ALS protocols in New York State. And for folks who are listening, both in New York and out of New York, certainly this is a challenge all across the world, is how do we incorporate evidence-based medicine best practice, considering that many of us may use different formularies, have different equipment, have different kit that we carry, in order to really optimize our patient outcomes, especially considering that the variables that each of us are dealing with or challenged with within our own unique communities are always going to be incredibly different depending on where you live, whether that be a 5-minute transport time or a 5-hour transport time. There's so many factors to consider when dealing with ill and injured patients in the out of a hospital sphere. So welcome back to the show, Chris.
I appreciate it, Faizan. We've actually had a wonderful opportunity to work with a number of professionals across the state and outside of the state in order to really get the best set of protocols I think that we could possibly put forth. This time around, we were really focusing on the basic life support. And those are a few of the things that I wanted to touch on here today. What we're going to be talking about today is not so much a comprehensive overview of every single change that we have in our protocols, but we wanted to touch on some of the key points and the differences compared with the previous version of the collaborative protocol specifically.
So for those of you folks who are listening from home, you can certainly download our New York State app. And for those folks who are listening from abroad or other locations or other parts of the country, certainly we appreciate your feedback. Reach out to us on Twitter at 87MD1 is Dr. Fullagar, and myself at EMS Crit Care, and let us know how your own regional protocols may vary and some things that you have found to be successful or not so successful. We're really going to be honing in on the changes in New York State. We're recording now in 2019 some ALS changes, and we're actually at the headquarters of a large simulation company recording some training videos and rollout for the BLS collaborative protocol rollout update for New York State. So very exciting stuff to come down the pipeline.
One thing that is really important is to get continual feedback here. So we really encourage you to take a look at the protocols, to give us your suggestions. This really is a living document on both the BLS and the ALS side of this. A lot of the changes that we see to the collaborative version of the protocols, for those of you in New York State, is really an incorporation of the new statewide BLS protocol, so that both of these documents are consistent with each other. One of the things that you'll see as far as the sections is that the pediatric protocols actually come directly after their adult version, so that there's not a separate section on pediatrics at this point. And talking about pediatrics, one of the changes that we did make was a bit of a change to the pediatric definition. Now, Faizan, as you know, that this is really kind of a moving target, and it's very difficult to really put a line in the sand as to when a pediatric patient all of a sudden becomes an adult patient. What we said was that as a general guideline, we're going to be utilizing pediatric protocols, at least that they should be considered, for patients who have not yet reached their 15th birthday. But this is important to keep in mind that within the medical control agreement contained within the protocol document, that providers are expected to use their best clinical judgment and deliver care and procedures according to what is reasonable and prudent for specific situations. And the determination of when to utilize an adult or pediatric protocol shall be no different and subject to the same CQI review that is compulsory with any other aspect of pre-hospital emergency care.
So pretty much it sounds like less than or equal to 15 from a technical standpoint, but of course providers should always use their best judgment and consider the case and scenario to optimize their care.
Exactly. There's another change in that we have a new general approach section, and that comes out of the statewide BLS protocol. There are a couple of things in this general approach section that I want to hone in on. One of which is the overall goal of this section is that we want to convey that we use common sense. So as far as safety and restraining devices, it is very important to properly restrain adults and kids to make sure that they are safe when we transport. In regard to our own safety, we oftentimes drill in our training in regard to scene safety. But as we all know, the reality of it is that scene safety is not a dichotomous yes or no question. It requires continual assessment, continual situational awareness, and just like we reassess our patient on a regular basis, we should also be reassessing the safety of the scene itself. So just keep that in mind, that this is a dynamic thing that changes from moment to moment, and you don't want to forget about that when you're in the middle of treating a patient.
Well said, Chris. As a new father myself, using a car seat to transport the infants, toddlers, newborns, etc., is just something that's at the forefront of my mind. And I know certainly providers all across the country are now using best practice and using infant car seats for transportation of children. Just having the wherewithal to ask the parents to bring that or have that ready if it is a pediatric call type, and especially if you're going to end up at a receiving or community hospital and ultimately need to transfer that patient, we still have to maintain the highest standards of safety in that regard.
And also going along with the concept of safety is the use of lights and sirens. And this certainly is something that's been talked about quite a bit. There's a fair deal of controversy. At the end of the day, there are a lot of things that go into the decision as to whether or not lights and sirens is appropriate. What we try to convey within the general approach to transportation is that the consideration of use of lights and sirens should be considered as a medical intervention. So is the patient's condition, does the time of day, does the traffic situation all warrant the use of lights and sirens, and is it really going to make a difference in patient care? That's something that's fairly difficult to put into a protocol per se, and this will vary based upon your local and your regional policies, but just so much as we can consider the use of lights and sirens within the context of the patient's condition.
I think just the element and focus on self-care there as a medical director, if we can insert that take-home point that many of us in EMS are working several jobs or working very long hours, multiple days of the week, and we are so focused on delivering high-quality patient care. And just to remember, in order to do that effectively, we must care for ourselves. And whether that be in the back of a moving ambulance trying to perform interventions that are otherwise unsafe, or just general regulation of sleep, nutrition, diet, and exercise, performing self-care as your medical directors, we just want to inform you all that are listening. This is a challenging aspect of day-to-day life, but something that we believe in strongly and advocate for, and would love to touch base. If you have questions, concerns, or commentary, please reach out to us, and we'd love to discuss with you more offline.
Completely agree. Switching gears a little bit now, just to go into speaking about cardiac arrest. One of the overall concepts, which is still kind of variable across the state, and I would imagine across the world as well, is where is the most appropriate place to work a patient in cardiac arrest? And again, this is another thing in which there are a number of factors that contribute to the answer to that question. But in general, the concept is that we feel as though working the cardiac arrest on scene will provide the best possible outcomes for the patient. And one of the things that we've learned over time is that high quality, uninterrupted compressions are extraordinarily important, and any sort of an interruption in that is deleterious to the patient's outcome. So whenever we move a patient, it is almost impossible not to interrupt those compressions. And basic life support, excellent basic life support, is really the key to maximizing the chance of a successful resuscitation. So even if there is a BLS crew and there is no immediate availability of advanced life support, if we can spend some time to do good quality compressions and try to complete the resuscitation to the extent possible, and at least have a discussion with medical control within about 20 minutes or so of starting to discuss what the best option for that particular patient at that particular time is going to be, whether it is transport or whether it is continuing with good quality BLS compressions. Those are things that we feel as though at that point, when you have the opportunity to discuss with medical control, that would be a good time to have that conversation.
I completely agree, and I know there are a lot of folks on EMSNation that are up to date and excited about the concept and the promise of ED ECMO and initiation of ECMO. I just wanted to highlight some of my heroes and role models, the EMS Medical Directors from the Twin Cities, RJ Frasco and his other colleague as well. They developed an entire system of care, starting from the dispatcher all the way up to the cath lab, and have very specific criteria for the initiation of some of these very advanced concepts. And the data is still forthcoming. So it takes tremendous amount of effort to create these sorts of programs, and maybe a certain amount of time in New York State, we may have centers of cardiac arrest excellence. But these are things that we're all working and striving towards, and that we still would require tremendous evidence base in order to incorporate into protocols or algorithms, not as simply as pilot projects or special projects. So while that evidence is incredibly exciting, the pilot projects are incredibly exciting, we firmly believe that you can deliver high-quality ALS, BLS care for your out-of-hospital cardiac arrest patients. Working the patient on scene has tremendous advantages, both for the patient as well as provider safety.
Absolutely, and I think you touched on a very important point there as far as where we are trying to be in our protocols. It is very challenging to determine what it is that is actually going to pan out to work well for the patient and what isn't. We don't want to be too far behind the curve, but also we know that being too far along the bleeding edge, so to speak, can also be problematic because things don't always pan out. So we try to find the best possible scenario within that. And one of the things that we tried last time was to convey the concept of double sequential defibrillation or dual sequential defibrillation. That was something that we considered for refractory ventricular fibrillation as kind of a last resort in order to try to maximize the vectors that are applied to the heart with defibrillation. But what we found is that the evidence doesn't seem to be supporting it, at least not to the degree that we had initially hoped. So you'll notice that it's no longer suggested in the protocol document as a medical control order like it was in the previous version, although at this point it's still not prohibited and it can always be used as a medical control consideration, but we have found as though it doesn't seem to be as beneficial as we had once hoped.
Along those lines, it's really about training the system of care, and in regards to cardiac arrest training, one of the biggest takeaways I can emphasize is perform the basics to the best of your ability. And that's high quality CPR, compression rate, depth, and allowing for adequate recoil. One of the biggest takeaways is if you can set up or facilitate interagency training to respond to your cardiac arrest, because you might have a volunteer BLS squad responding, a municipal fire CFR squad, as well as a private ALS, and the people that show up on scene may have never worked together. So really, in regards to cardiac arrest improving outcomes, facilitate interagency training at the local level to really improve outcomes and tighten up that entire integration and system of care and chain of survival.
And as far as training goes, there really is nothing like actually doing it. And the people who are mediocre versus the people who are excellent, really the difference is in the details. And the only way to really iron out those details or even identify the details in the first place is to actually go through and do it and see see what's working well, see what's not working well. Get that muscle memory training going so that when the time comes, you can dedicate your cognitive bandwidth to certain things that may be a little bit more dynamic, and you don't have to waste that bandwidth on things that you may already be able to train so that essentially it becomes second nature.
Now, in regards to something becoming second nature, it's a concept that if we have incredible familiarity with the procedure, we're performing it on a regular basis, we have continued medical education, then that's when, if we're performing a critical intervention or procedure, the benefits may outweigh the risks. And I think on the national trend, and we've certainly reviewed articles in Journal Club in regards to pediatric intubation, the facts is unless you are a critical care flight retrieval team that sees many of these patients on a weekly or monthly basis, intubation of pediatric patients can potentially be harmful.
I think that intubation in general is something that, regardless of your experience, regardless of your level of training, it doesn't seem to be as critical, and it doesn't seem to impart the improvement in outcomes that we had once hoped either. So this is one of the things that, as we mature as far as a medical community and we're continually learning, we find out things that really work well and things that really don't. And intubation is actually one of these, especially on kids. One of the nice things about children is that their airway is usually, we're able to manage that without intubation actually quite effectively. And intubation in children is something that is kind of a last result. And this is similar to what we had in the previous version of the collaborative as well, in that if there's any way to effectively oxygenate and ventilate the child without intubation, that is what we should be doing, and only reserving intubation for those cases which are absolutely necessary to achieve basic ventilation and oxygenation.
And one of the things we'll be emphasizing in the BLS statewide rollout simulation training videos is the BLS airway. It's one of those things you have to walk before you can run, and so we get excited about the critical care procedures, but really in terms of patient outcomes, a highly effective BLS airway has the greatest potential to change your patient's outcomes.
I'm actually going to take that a step beyond and say that you can actually run very well with an excellent BLS airway. This is something that is important for advanced providers like paramedics and EMS physicians to keep in the back of your mind, is that when you're in the field environment, if you can manage an airway with excellent BLS skills, a lot of times that's where your limited resources in the field are best spent. So having that opportunity to practice, to train, to get those nuances of managing the airway at a BLS level, that's really, I think, where we're going to have the most bang for our buck, so to speak.
And one more point on that, just for paramedics who may be saying or questioning, hey, why are these medical directors trying to take away things in my skill set? There's absolutely no ego in this conversation. So I want to just highlight one of my personal mentors, Dr. David Cohn from Yale, just initiated a conversation and thread on the NAEMSP website for physician medical directors. And his argument was, hey guys, maybe we should actually establish training and guidelines for EMS physician out of hospital intubations, because he, as a professor of emergency medicine and an EMS medical director, just felt that in regards to the out-of-hospital intubations, they weren't doing enough to maintain competency, and so wanted to get the insight of the whole academic community to say, even at the EMS physician level, what are the guidelines, recommendations, best practice, and CME that we should institute upon ourselves so that we are actually doing the best thing for our patients?
Right, and this actually even goes beyond competency, because even people who are very competent in doing so, we found that the outcomes just aren't there. So one of the next things I just want to touch upon is the return of spontaneous circulation. A lot of times when we are resuscitating a patient and we get ROSC, we kind of feel that the goal has been met and we can take a breather, sit back, give some high fives, and relax. But I would say that once you achieve ROSC, that's really where the medical care begins. And before you scoop and run with that patient, it is best, we feel, to stabilize first and assess the patient. Make sure that you have a good blood pressure. Make sure that we can decrease the chance that the patient would go back into cardiac arrest. And one of the other important things is to assess a 12-lead ECG. If that patient initially went into cardiac arrest because they were having a STEMI, and now once the patient has achieved ROSC, that STEMI is apparent on the 12-lead, if you have the opportunity to take that patient directly to a cath lab, depending on your local resources, that may be the best option for that patient. And being able to mobilize those resources early before transport may actually help with the improved outcome of that patient.
Now, there's a different end of the spectrum, and those are patients, irrespective of what you do, are not going to come back from cardiac arrest, and these are the obvious death patients.
So in obvious death, we have a number of criteria, and one of the ones that I wanted to highlight is the criterion in regard to the traumatic arrest patient. You'll notice with the obvious death protocol that if you compare the collaborative with the statewide BLS, there's a little bit of a difference, and that has to do with traumatic arrest patients. A patient who is pulseless and apneic with no organized cardiac activity on ECG is considered a patient who has met the criteria for obvious death. Now, the no organized cardiac activity on ECG obviously requires an ALS provider in order to do that. So that's the reason why you're not going to see this on the BLS statewide protocols. So in regard to this, if you do have a patient who is in traumatic cardiac arrest who has organized cardiac activity on the ECG, there are only a few things that are potentially reversible in the field. And one of those things is a tension pneumothorax. So at that point, bilateral chest decompression is indicated.
Yeah, absolutely. The approach to traumatic arrest can be challenging, but working through those H&Ts, and perhaps there will be a day in the future where as 911 providers we'll also be carrying pre-hospital ultrasound to help us differentiate some of these things. So more to come on that in the near future, certainly.
There are a few changes in regard to the outline of the collaborative protocols in order to allow them to be more in line with the statewide BLS. Within the statewide BLS protocols, a patient who is hypoglycemic will be managed according to the altered mental status protocol. So in the collaborative, we do have an altered mental status protocol with a link to a separate hypoglycemia protocol that outlines the advanced life support procedures to be used with a hypoglycemic patient. So I just wanted to point out that there may be a little bit of a difference there between the statewide BLS and the collaborative as far as where that actually lives. In regard to tachycardia, one of the questions that has come up is in regard to narrow, complex, regular, stable tachycardia. Within the collaborative protocols, it says to start at 100 joules. There was a question that was posed in regard to escalating doses and whether or not that was indicated under these protocols. This is intended to allow for the treatment of narrow complex tachycardia according to the current ACLS recommendations. So we're going to consider changing that wording a little bit in order to make that more clear, but the escalating doses in regard to treatment of narrow complex regular stable tachycardia is not prohibited and actually supported by the protocol document.
And on the flip side, as a mention of best practice, if you have not exercised or drilled your symptomatic bradycardia protocol and actually practiced transcutaneous pacing in the last year, I strongly encourage you to work on that, create a simulation exercise, discuss that with your partners, because this is one of those high acuity, low occurrence cases that we really have the opportunity to make a difference in our patients' outcomes, but we would need to act quickly, efficiently, and competently.
Absolutely. I agree. Switching gears once again to opiate overdose, there's another thing that I'd like to just clarify, that in our protocols, both in the collaborative and the statewide BLS, we talk about naloxone. And typically speaking, for intranasal naloxone, we suggest 2 milligrams for adults, that being 1 milligram in each nary, and 1 milligram or half the dose in pediatric patients, that being a half a milligram in each nary. But we also have the provision to utilize a commercial device that delivers 4 milligrams in 0.1 mLs. Now, that device is permitted for use in both adults and pediatric patients. So both adults and pediatric patients with the use of the device will get the full 4 milligram dose in a single nary. And that's something that I just wanted to clarify because there may be some confusion in regard to the doses. The next thing is the organophosphate exposure protocol and the comparison between that and the weapons of mass destruction disaster resource. In the previous version of the protocols, we had a weapons of mass destruction mass casualty protocol that was essentially a reflection of the New York State Bureau of Emergency Medical Services policy statement 03-05. And essentially that outlined very specific instances in which the statewide Mark I kit resource would be mobilized. Because this is actually more of a policy statement that has patient care implications as opposed to a protocol, the weapons of mass destruction disaster resource was put in the resource section. And the organophosphate exposure protocol doesn't have pyrrolidoxine, which is not part of our typical pre-hospital care formulary. In either instance, organophosphate or weapons of mass destruction intentional exposure, the way that we are going to save most of the patients is not going to be with the administration of atropine or pyrrolidoxine or any of the medications that we typically use. It's really going to be with excellent basic life support, respiratory support, suctioning, positioning, airway management. With intentional organophosphate exposures, for example, those that are intended as a suicide attempt, we may have a requirement for more atropine than we would carry. So once we exhaust that, we're only left with excellent BLS skills in order to save that person's life. In weapons of mass destruction, the Mark I resources may not be readily available. And once again, we may exhaust those very quickly. So airway management, suctioning, position is really the key in these cases.
Also, I have to emphasize you must have appropriate PPE in this situation or scenario in order to protect yourself and not become a patient yourself or your partner become a patient themselves. In addition, decontamination of the patient and your fire colleagues or hazmat colleagues may be instrumental. And of course, in the setting of a potential terrorist attack or WMD attack or a nerve agent exposure, those are potentially chaotic experiences that, again, we would want you to try and simulate and exercise and drill within your local municipalities. Here in Dutchess County, New York, we do have a drill coming up on May the 4th. Some will appreciate the Star Wars reference on this exact situation. So if you hear this podcast and are available to come down, you're more than welcome to participate in that.
The next topic I want to touch on is shock. And shock has various flavors that are going to be treated in different ways. We have different shock protocols within the collaborative, one of which is shock hypoperfusion. Another is severe sepsis and septic shock. There's a cardiogenic shock protocol and a trauma-associated hypoperfusion protocol. And each one of those has different approaches and different goals of treatment based upon the underlying causes.
So think through those, appreciate the differences in management, and just be adept in regards to discussing the various physiological and anatomical and pathophysiological differences that may exist in that patient population.
I wanted to touch upon stroke care, which is actually reflected in our basic life support protocols. This is something that is fairly dynamic. There's a lot of discussion. There's a lot of new information out there. And this is something that I would encourage everybody to keep a close eye on, because I think as time goes on, there are going to be further advancements in regard to stroke care in our state. A couple of things that you may notice that are a little bit different from the last version is that we have two different times of onset, essentially. One is the last known well time, and the other one is the time of symptom onset. And those two times may actually be different. The last known well is the time that we have previously noted in the protocols. And essentially, that is when the patient was last seen without any deficits at all. The time of symptom onset, however, is the time in which the symptoms were first noted. And according to stroke guidelines, both of those times would need to be noted on the stroke record in the hospital.
This is going to become increasingly important as we in the pre-hospital sphere are trying to help and optimize patient outcomes. So of course, TPA is a potential adjunct. But what we're becoming more adept, and the cognitive frame is changing for us, is not the question, is my patient having a stroke, yes or no, but rather is the question, is my patient having a stroke due to a large vessel occlusion, yes or no? And that might change your decision making in some regards in potentially transporting that patient to a thrombectomy capable center, depending on the overall time of onset and things along those lines. And this is an area of active research in the out-of-hospital and pre-hospital sphere. There are several stroke severity scales that are currently being researched and piloted in various EMS communities across the country to try and see if there's a surrogate that can help us improve our pre-test and post-test probability of detecting a large vessel occlusion based on physical exam. So the way I'd like to teach this is a stroke severity scale is almost a parallel to your 12-lead ECG in regards to STEMI care. So there's some people who may have some ischemic changes but not require urgent catheterization. The stroke severity scale is trying to decipher whether the patient has high probability of a large vessel occlusion.
Within New York State, the Cincinnati Pre-Hospital Stroke Scale is still considered the standard. We need to perform a thorough neurologic exam and include the Cincinnati Stroke Scale, although we are aware that there are limitations of the Cincinnati scale that will miss certain actionable strokes. So within the protocol, we do suggest that you perform the Cincinnati Stroke Scale, but also allow for other regionally approved and indicated stroke scales. And this also speaks to the fact that this is an evolving area of research and an evolving area where we are gaining more knowledge as time goes on. One of the things that is going to be changing is the time from last known well or time of symptom onset to the estimated time of arrival to the emergency department should be less than 3.5 hours unless otherwise regionally designated. Now, this has implications as to whether or not your stroke center can perform interventional maneuvers or if they are simply going to only be able to administer fibrinolytic medications. It is very important that when we try to make these decisions, especially in the more outlying areas where we may not have ready access to an advanced stroke center, to discuss this with medical control and to discuss an appropriate destination facility for your particular patient at that time. We have another resource here. It's actually a protocol in regard to technology-assisted children. And this provides some basic guidance on various devices that the children may have. We have more and more patients who are being managed as an outpatient who may have tracheostomies or feeding tubes or other catheters which typically are not encountered every day in the pre-hospital environment. The purpose of these protocols are to familiarize the providers with some of these devices and some of the basic management that we can do out in the field in order to assist these children. We also have protocols in regard to patients with total artificial heart and ventricular assist devices, along with children who are being more supported with technology, we also see adults with this advanced technology that previously would require inpatient stays in the hospital. Now patients with total artificial hearts and ventricular assist devices are afforded the freedom to go out and about and actually live fairly normal lives with these devices that are required to support their circulation. So in that regard, they may encounter complications out in the field, and we're going to need to know how to manage that as well. So these protocols provide some basic guidelines in regard to this. In regard to burn care, I get the question as far as whether or not it is appropriate to apply dry dressings or wet dressings. The default answer is to always apply dry dressings because we don't want to predispose our patients to getting hypothermia, especially if they have a large burn surface area. But if that burn surface area is very small, typically less than 10%, and we feel as though applying moist dressings is going to assist with pain control, that is appropriate to perform under these protocols. But for any larger burns, we want to make sure that we don't apply wet dressings, only dry dressings, because we can very, very quickly precipitate hypothermia in these patients. The use of tourniquets is something that we see being more and more ubiquitous out in the field. We oftentimes will have law enforcement or even lay people start to apply tourniquets for control of massive bleeding. One of the side effects to this is that we will see tourniquets that are applied to bleeding that is not considered life-threatening or relatively minor bleeding. In regard to tourniquet use, we don't want to take down a tourniquet that is applied for true life-threatening bleeding. We want to keep that tourniquet up. In the past, we have considered intermittently loosening the tourniquet to allow for blood flow to the limb. And we found that in the setting of life-threatening hemorrhage, that can actually be very counterproductive and detrimental to the patient. But if you do find that as a provider, there is a tourniquet that was placed for apparently non-life-threatening bleeding, you may take that tourniquet down, but just make sure that you have the ability to rapidly and adequately control massive bleeding should it occur. The last topic in regard to hemorrhage has to do with impregnated versus non-impregnated packing. If we have a large wound that is, for example, in a junctional area, like the groin or the axilla or the base of the neck, in an area that is not amenable to utilizing a tourniquet, we want to make sure that we have good, tight packing against that bleeding artery. So it is important to make sure that if there is a blood clot that's preventing direct access to the vessel, that we remove that blood clot and that we get that packing as tight as possible right up against the artery. If you have some type of hemostatic impregnated gauze, that's great. But the important concept here is that you can also use non-impregnated gauze because the main thing in regard to packing is to get that pressure directly up against the artery. Oxygen administration is another thing that we have talked about quite a bit. In the previous set of protocols, we initiated a bit of a paradigm change in which oxygen was only used in cases where a patient was hypoxic or in respiratory distress. We realized that some basic life support agencies may not be able to routinely assess for oxygen saturation. So if you have a patient who is in respiratory distress or you feel as though the patient is working hard to breathe, it's appropriate to apply supplemental oxygen to that patient. Generally speaking, an oxygen saturation of less than 94% is something in which we may want to consider applying oxygen to. It's important to realize that some children with cardiac conditions, particularly congenital cardiac conditions, may normally have an oxygen saturation of 65 to 85%. This is where the parents will be able to give you important information because they will be able to tell you what the child's oxygen saturation is in most cases. In regard to patients who are unstable or critical patients who are dynamic in their physical condition, it is acceptable to apply high-flow oxygen to these people if there's a concern that episodes of hypoxia may be missed. We do know, for example, in major trauma, patients who are hypoxic in the setting of trauma really don't do well at all and have significant increase in the probability of poor outcomes, even with transient hypoxia. So if you have a patient who is very critical or very unstable, it is acceptable to apply high-flow oxygen from the get-go in those cases. The last thing that I wanted to touch on for today is refusal of medical attention. And this was something that was previously relegated to regional policy and procedure, and there still may be associated regional policy and procedure for this, but we did want to put a minimum requirement within the protocol document across the state. One of the things in regard to refusal of medical care is that for a patient that has any potential illness or injury, an EMT or higher is required in order to take a refusal or to cancel an ambulance. A CFR may only take a refusal of care or cancel an ambulance if there is no indication of possible or potential illness or injury. If we have a patient for whatever reason does not have the capacity to refuse care and requires involuntary transport to the hospital, we may need law enforcement to assist in these cases. The important thing to convey in this instance is that we're not asking law enforcement to take the patient into protective custody. Instead, we are asking law enforcement to assist us in safely managing that patient in order to get them to the hospital without injury to the patient or injury to the staff. And that's the extent of what we're asking law enforcement to do.
I completely agree, Chris. In regards to RMAs, I definitely encourage providers to document appropriately, not only A&O times 3 or 4, but specifically the decision-making capacity, which is distinct from their alert and oriented status. As well, it may be worthwhile, depending on the protocol, to call into your actual hospitals, have a physician speak with the patient, and record that conversation on a recorded line if you suspect that the potential for adverse outcomes could potentially be high. The cases I personally see most often are diabetic emergencies that are improved after some administration of medication or food, asthma exacerbations that improve after nebulizer treatment, and I think what's more and more common and is challenging for some of us, both ethically and medical legally, is the opiate overdoses after Narcan reversal.
So all of these things are definitely things that require some degree of medical judgment, and that is really what capacity is. It is going beyond just alert and oriented times 3 or alert and oriented times 4, and actually making a determination based upon your clinical assessment of the patient as far as whether or not the patient is able to process the information effectively to really understand what the potential risks of refusal versus the benefit of treatment are.
All right, folks, that's what we have today for some of our protocol updates. Please stay tuned for our BLS protocol update simulation training videos. And whether you're a critical care flight paramedic or retrieval nurse or a ground 911 EMS provider, really the takeaway points will be high quality BLS care has incredible potential to save lives. And just like any other specialty, we need to train to the highest standards. And with that, this is Faizan Arshad and Chris Fullagar wishing everyone a safe tour.